Welcome to the weekly Neurology Deep Dive, produced by America Vanini. Our purpose here is purely educational, without any commercial goals, and we aim to provide you with a concise summary of complex source material.
And just a reminder, as always, we strongly recommend you consult and read the full paper for complete and comprehensive information. This is really just a summary for discussion.
Absolutely. Today, we're embarking on a deep dive into the world of preventative treatments for episodic migraine. Our insights are fresh from a recent systematic review and meta-analysis of randomized controlled trials.
And it's quite a comprehensive one.
It really is.
Yeah.
This isn't just a breakdown of data. It's a critical look at how we can, better manage this challenging condition for our patients.
Right.
Now, for those of you with incredibly demanding schedules, maybe just catching this between patients, here's the essential takeaway up front. Anti-CGRP monoclonal antibodies and gepants stand out as highly effective first-line choices.
Yes, the data really supports that. They significantly reduce the number of monthly migraine days and the need for acute medication.
And importantly, with a favorable tolerability profile, that really encourages patient adherence.
Exactly. In contrast, you see more traditional agents like, say, topiramate and propranolol that show more modest efficacy and are often associated with higher rates of adverse events.
Which can be a significant barrier for many patients, leading to discontinuation.
A huge barrier. We also saw that combination therapies can indeed offer greater efficacy, but this often comes with the trade-off of increased side effects.
It's always that balance, isn't it?
It is. And crucially, non-pharmacological treatments are showing real promise as valuable adjuncts, particularly given their generally excellent safety profiles.
So the overarching message, then, seems to be a strong call for individualized, multimodal preventive strategies in our clinical practice.
Precisely. That's the key takeaway.
Throughout this deep dive, we'll unpack the core data from this review, explore specific medications and therapies, delve into their benefits and adverse effects, and crucially, discuss where each fits into a practical therapeutic plan for your patients. Let's get started.
Okay. Well, first, just framing the problem. Episodic migraine is a neurological disorder that truly defines disabling. It affects millions globally, with a disproportionate impact on women.
It's not just a headache, is it? It's a significant burden.
Not at all. It represents a huge burden of lost productivity, reduced quality of life, and considerable healthcare costs. For clarity, the study defines episodic migraine as recurrent attacks lasting from 4 to 72 hours, occurring on fewer than 15 days per month.
And it's vital that we address the critical gap this study aimed to fill. The objective was evaluating the comparative efficacy and safety of both pharmacological and non-pharmacological preventive treatments.
Right, an area that surprisingly hasn't been as thoroughly addressed previously in this comparative way, especially thinking about implications for low and middle-income countries.
So how did they go about it, the methodology?
Well, the study rigorously followed the preferred reporting items for systematic reviews and meta-analyses guidelines. That's the standard. PRISMA. The researchers undertook an exhaustive search across major databases, Wiley Online, BVS, Medline, Ovid covering literature, up through November 2024. A very current search.
And their inclusion criteria, what studies made the cut?
They were quite precise. Adult patients, 18 or older, with a confirmed diagnosis of episodic migraine. They focused exclusively on randomized controlled trials, specifically Phase 2 or Phase 3 studies.
Right, looking at prevention.
Exactly. Evaluating preventive treatments, both pharmacological and non-pharmacological. And these trials had to report outcomes for reduction in monthly migraine days, monthly headache days, acute medication days, and of course, adverse events and serious adverse events.
So what was excluded then?
They filtered out in vitro or Phase I trials, non-randomized studies, and studies focused on other headache types like tension headache, or those primarily looking at acute treatments like NSAIDs, triptans, or ergot alkaloids used acutely.
Makes sense. And the scale of this review sounds substantial.
It really was. Ultimately, it encompassed 39 randomized controlled trials involving over 15,000 patients. The publication spanned a long period, from 1987 all the way to 2024.
15,000 patients, that's a large data set. And the key outcomes.
The primary efficacy outcome was the reduction in monthly migraine days. Secondary efficacy included monthly headache days and the reduction of acute medication days.
And safety.
Primary safety outcome was the presence and frequency, or percentage, of adverse events and serious adverse events.
How did they assess the quality of these trials? Risk of bias.
They use the Cochrane risk of bias tool for randomized trials. It's the gold standard. They generally observed an overall low risk of bias in the intention to treat analyses, which gives us, more confidence in the aggregated findings.
Okay, good. So what was the overall finding for allopathic treatments versus placebo?
Well, the meta-analysis showed a significant reduction in monthly migraine days of about 1.25 days. This was statistically significant.
1.25 days. How does that translate relatively?
It translates to a relative reduction of approximately 17 to 28% from a typical baseline, which they noted was around 4.5 to 7.5 monthly migraine days. So, clinically meaningful.
Okay, now let's move into the heart of it. The specific pharmacological therapies. We should probably start with the anti-CGRP monoclonal antibodies erinumab, fremanezumab, galcanezumab, eptinezumab. What did the study show there?
Yeah, what's really striking about the anti-CGRP monoclonal antibodies is their consistent and clinically relevant efficacy. We saw reductions in monthly migraine days ranging from about 3.2 to 4.3 days.
That's quite a reduction. Over what time frame typically?
Mostly at 12 weeks, though galcanezumab also showed strong results out at 6 months. Importantly, they also led to a reduction in acute medication days between about 1.1 and 3.7 days per month.
And the safety profile, adverse events.
Adverse events ranged from about 19% up to 58%. The most common things were upper respiratory infections, injection site reactions, constipation, and fatigue, things we often see in practice.
And serious adverse events.
Less frequent, thankfully, occurred in about 1 to 4% of patients. Things reported included abdominal pain, asthenia, and bronchiectasis.
So where do they fit in therapy now? First line.
Yes, they're considered effective first-line options. This is due to their specificity, their targeted mechanism, and that favorable tolerability profile, which often leads to better treatment adherence compared to older options.
Okay. And the certainty of evidence.
It was rated as moderate. This was mainly due to some imprecision across the different trials included.
Got it. Now, what about the oral gepants? Remagepant, atogepant. They offer that convenience factor. How do they stack up?
Well, the gepants, they do offer pretty comparable efficacy, actually. The study showed significant reductions in monthly migraine days, ranging from about 3.6 to 4.4 days at 12 weeks.
Very similar numbers to the monoclonals and other headache measures.
Yes, they also significantly reduced monthly headache days by about 3.9 to 4.4 days, and acute medication days by about 3.3 to 3.9 days. So robust effects across the board.
What about their side effect profile?
Adverse event rates were a bit more variable, ranging pretty widely from about 10% up to about 64%. Predominantly nausea, constipation, and fatigue were reported.
And anything serious to note?
Serious adverse events occurred in about 2 to 4% of patients. These included allergic reactions and fatigue. It is worth noting, specifically for rimagepant, there were rare reports of acute myocardial infarction and cerebrovascular disease mentioned.
Important context. So their place in therapy, also first-line contenders.
Yes, there are also strong contenders as effective first-line options, really comparable efficacy-wise to the monoclonals. Though, as you noted, those gastrointestinal side effects might require careful consideration for individual patients.
And the evidence certainty for basins.
Rated as high, the findings were robust and consistent across the studies included for them.
Okay, let's shift gears now to the more established traditional pharmacological treatments. Anti-seizure medications, first topiramate, Valpro, oxcarbazepine. What did this review highlight about their current role?
Well, while these have been mainstays for years, the review really shows more modest efficacy compared to those newer classes we just discussed. Monthly migraine day reductions range from about 1.3 to 4.2 days.
So potentially overlapping with the lower end of the newer agents, but maybe less consistent.
Possibly. Valpro showed a reduction of about 1.2 days in monthly headache days, and oxcarbazepine reduced acute medication days by about 1.2 days. But the really significant challenge with these is the high frequency of adverse events.
Right, that's often the limiting factor in practice. How high?
Affecting about 60 to 80% of patients. We're talking common issues like paresthesia, weight loss, dizziness, and those cognitive effects, the dopamax issues that can significantly impact quality of life and often lead to discontinuation.
And serious adverse events.
They range from about 2 to 15%. Oxcarbazepine specifically had reports of acute vestibulopathy in some cases. So their higher adverse event rates really limit their applicability, perhaps more for specific patient profiles or if other options fail or aren't tolerated.
Okay. What about beta blockers? Propranolol, metoprolol, nebivolol, Similar story there.
Yes, the profile for beta blockers is quite similar in terms of modest efficacy and tolerability challenges. They demonstrated monthly migraine day reductions from about 1.2 to 4.2 days.
Again, that similar range.
Right. However, information on monthly headache days and acute medication days wasn't consistently reported across the trials they reviewed.
And adverse events.
Frequency varied quite widely, actually, from about 18% all the way up to 93% in some studies. Common complaints included fatigue, dizziness, and gastrointestinal issues.
Any serious events noted?
Ranged from about 4 to 7%. Metoprolol had reports of heartburn, and nebivolol reported sleep disturbances. So, like the anti-seizure medications, their modest efficacy combined with potentially high adverse event rates suggests they might be better suited for patients with specific comorbidities, like hypertension, or perhaps those who haven't found success elsewhere.
We also saw data included on angiotensin receptor blockers, specifically candesartan. What was its contribution?
Candesartan showed a reduction in monthly migraine days of about 1.8 days and monthly headache days of about 2.9 days, both measured at 12 weeks.
Oh, okay. Acute medication use.
That wasn't reported in the studies they included. Adverse event frequency reached about 50%. Primarily respiratory infections, dizziness, and sleep problems were mentioned.
Serious adverse events for candesartan.
Not specified in this particular analysis.
All right. Antidepressants are another class sometimes used: amitriptyline, venlafaxine, escitalopram. What were the findings there?
For antidepressants, the monthly migraine day reductions varied quite broadly, from about 1.8 day up to a quite high 7.8 days, evaluated over 8 to 12 weeks.
That's a huge range.
It is. But data on monthly headache days and acute medication days were not consistently reported, making comparison difficult. Adverse event incidence also varied incredibly widely, from basically 0 in some reports up to 100% in others.
Wow. What kind of adverse events?
Commonly included drowsiness, fatigue, nausea, weight gain. Specific issues were noted too, like dry mouth and hypersomnia with amitriptyline and tachycardia with venlafaxine.
And serious adverse events with antidepressants.
Also a wide range reported, from about 1% up to about 34%. This included things like severe sedation and cardiovascular symptoms, orthostatic hypotension in some cases. So efficacy is variable, and side effects can be significant.
Definitely needs careful patient selection. Okay, moving on to some other, maybe less conventional pharmacological approaches. What about melatonin?
Melatonin, studied as a hormonal therapy, showed a monthly migraine day reduction of about 2.8 days at 8 weeks.
Tolerability.
Seemed quite good. Only about 3% of patients reported adverse events, like fatigue and dizziness, and no serious adverse events were reported.
Interesting. What about NK1 receptor antagonists like linepatint?
Linepatint provided a pretty modest reduction, about 0.9 monthly migraine days at 12 weeks. No data was available for headache or acute medication days.
And the downside?
Adverse events were reported in about 52% of participants, things like headache and gastrointestinal symptoms. Serious adverse events occurred in about 2%, including nausea and heart palpitations, so perhaps limited utility there.
How about standard NSAIDs, like aspirin, used preventively?
Aspirin showed a modest 1.3-day reduction in monthly migraine days, but this was over a very long-term evaluation at 36 months.
Long-term adverse event data.
Not reported in this analysis for aspirin used preventively.
Okay. And finally, in this miscellaneous group, NMDA antagonists like memantine.
Memantine led to a reduction of about 3.5 monthly migraine days at 12 weeks. Acute medication days, interestingly, remained unchanged.
Tolerability.
About 13% experienced adverse events, mainly dizziness and fatigue. Serious adverse events weren't specified.
All right. Let's touch upon herbal supplements and oils: tanacetum, ginger, basil essential oil. Did they show much promise?
Well, the herbal supplements showed quite variable efficacy. Monthly migraine day reductions range from a very small 0.2 days up to 3.2 days at 12 weeks.
Any standouts?
Ginger specifically also led to a reduction of about 0.8 monthly headache days and about 0.9 acute medication days. So some signal there.
And safety.
Adverse event frequencies varied from about 8% up to 35%. Typical things included nausea, diarrhea, skin irritation, heartburn. It is important to note, though, that ginger was associated with a serious adverse event rate of about 7.5%.
7.5% serious adverse events for ginger is noteworthy.
It is. So while some show promise, efficacy is variable, and the adverse event profiles and consistency need careful consideration, just like with pharmaceuticals.
Given the challenges we've discussed with single agents, especially tolerability, clinicians often explore combination therapies. What did the review find about combining treatments like topiramate with amitriptyline or propranolol with nortriptyline?
Combination therapies, perhaps unsurprisingly, achieve the most pronounced monthly migraine day reductions overall. The range was from about 2.6 days up to 5.1 days, typically evaluated between 6 and 12 weeks.
So potentially the highest efficacy ceiling.
Potentially. However, detailed data for monthly headache days and acute medication days were largely unavailable for these combinations in the review.
And the inevitable trade-off, adverse events.
Exactly. While efficacy was enhanced, the adverse event frequency ranged significantly, from about 15% up to about 66%.
What kinds of issues were common?
A whole host. Sedation, weight gain, dizziness, dry mouth, paresthesia, fatigue, loss of appetite, memory disturbances, gastrointestinal issues, somnolence, a long list.
And serious events.
Reached up to about 4%, primarily involving sedation and dizziness.
So it really underscores the need for a highly individualized risk-benefit assessment when considering combinations.
Absolutely. The certainty of evidence for these combination therapies was rated as low. This was due to heterogeneity between the studies, the use of indirect comparisons, and often smaller sample sizes.
Okay, that covers the pharmacological side extensively. Let's turn to another fascinating area. Non-pharmacological therapies. These are often appealing to patients, aren't they? Different mechanisms, potentially better safety. What about transcutaneous occipital nerve stimulation?
Yes, these non-pharmacological interventions showed some promising effects. Transcutaneous occipital nerve stimulation, or TONS, yielded reductions in monthly headache days. Note, headache days, not migraine days specifically reported here, ranging from about 2.0 to 5.5 days at 1 month, depending on the stimulation frequency used.
And side effects.
Reported in up to about 25% of patients, mostly local things like pain or hematoma at the stimulation site, some nausea and dizziness. No serious adverse events were reported.
What about caloric vestibular stimulation, CVS?
CVS demonstrated a reduction of about 3.9 days in both monthly migraine days and monthly headache days at 12 weeks.
Okay, consistent effect there. Acute medication use.
Yes, the same intervention showed a reduction in acute medication days of about 3.9 days as well, so hitting multiple endpoints.
Tolerability of CVS.
Most frequent adverse events included nausea, dizziness, ear discomfort, and tinnitus. Again, no serious adverse events reported.
And acupuncture, a common non-pharmacological approach.
Acupuncture showed a reduction of about 2.5 days in monthly migraine days compared to about 1.0 day in the sham acupuncture control group, measured at 12 weeks.
So better than sham.
Correct. Monthly headache days and acute medication days weren't reported for acupuncture in this review. Adverse events occurred in about 25%, mostly local pain and hematoma at the puncture sites. No serious adverse events.
So the overall take on these non-pharmacological options.
They certainly yield promising effects, and their generally favorable safety profile is a major plus. However, a key limitation highlighted was the lack of uniformity in outcome measures across studies, and, frankly, fewer well-controlled trials compared to the drug studies. This hindered a full quantitative meta-analysis.
But their potential role.
Significant, especially as adjunctive treatments within an individualized preventive plan. Their safety profile makes them attractive additions.
Okay, so after diving deep into all these options, pharmacological and non-pharmacological, it's important we circle back and acknowledge the limitations of the review itself. What did the authors point out?
Well, a significant limitation was the exclusion criteria. Patients over 65, pregnant women, and individuals with significant cardiovascular or cerebrovascular conditions were excluded.
Which definitely restricts generalizability to those common patient groups we see.
Absolutely. There was also variability in the follow-up periods across studies, mostly 3 to 6 months, which might not capture long-term effects or adverse events fully. And as with any review, there's the potential for publication bias and language bias.
Did they mention homeopathic treatments at all?
Briefly, they noted that homeopathic treatments, when analyzed, showed a global mean difference of about 0.79 in monthly migraine days, which was not statistically significant compared with placebo.
Okay, so this brings us back, really, to the core message for our daily clinical practice.
Yes, this systematic review powerfully reinforces that critical need for truly individualized preventive therapy for episodic migraine. There's no single best answer for everyone.
Treatment decisions have to integrate so much, don't they?
They really do. You have to consider the patient's comorbidities, the specific adverse effect profiles we've discussed for each intervention, and crucially, patient preferences and lifestyle.
And the importance of combination strategies seems clear when appropriate.
Yes, combining pharmacological and non-pharmacological approaches often leads to the most comprehensive and tolerable management plan. We also need to be mindful, practically, of the global challenge limited availability of some newer agents in certain regions.
Which underscores our responsibility as clinicians to advocate for equitable access where possible.
Exactly. Aligning with international standards of care should be the goal.
And looking ahead, what does this review suggest are the key needs for future research in this area?
There's a very clear call for more high-quality head-to-head trials,
Yeah.
especially comparing the newer agents directly against each other and against established standards.
With longer follow-up.
Yes, longer follow-ups are needed, along with larger sample sizes. This will help confirm long-term safety profiles and the actual duration of therapeutic effects.
Anything else?
The review also highlights the need for more research into subgroup-specific responses, who responds best to which treatment. And, critically, robust cost-effectiveness analyses are needed to help guide choices within different healthcare systems.
Makes perfect sense. So, to bring it all back home for our busy clinicians listening, let's reiterate those core insights one last time.
Okay. The key takeaways are anti-CGRP monoclonal antibodies and gepants stand out as highly effective first-line options. They significantly reduce monthly migraine days and acute medication days, and generally do so with good tolerability.
Compared to traditional agents.
Right. Traditional agents like topramidate and propranolol generally offer more modest efficacy and come with higher rates of adverse events, limiting their use for many.
Combination therapies.
Can increase efficacy, potentially achieving the best results, but often at the cost of increased side effects and complexity. Needs careful consideration.
And the non-pharmacological options.
They are valuable adjuncts, their results are promising, and their favorable safety profiles make them attractive components of a multimodal plan.
So the bottom line remains, an individualized, multimodal approach to prevention is key for effectively managing episodic migraine in your patients.
Absolutely, that's the central message.
Which leads us to a final thought for reflection. As neurologists, armed with this evolving data, we're really empowered to move beyond a sort of one-size-fits-all approach and truly tailor our preventive strategies. So how might these insights encourage you to reevaluate or perhaps expand your current management plans for episodic migraine?
Especially considering that crucial balance of efficacy, tolerability, and of course your patient's unique profile and preferences. It's a lot to integrate.
It is indeed. We want to remind you once more that this deep dive was for educational purposes only. It has no commercial goal, and we strongly encourage you to consult the full paper for the complete information and context.
Thank you for joining us on this weekly Neurology Deep Dive.